Thank you. We are happy to ask Shams Iqbal to give us a talk today on the management of BPH, prostate artery embolization. I asked Shams to give us a talk because he's probably the doc you guys refer to all the time and probably never know or never met him. And he does all sorts of things to your patients with all sorts of different catheters and needles and stuff to that effect. Shams is a great resource for us in Newton-Wellesley, and I'm excited to hear about.
I can turn mine off.
So if we either way, yeah. Okay.
And we're excited to have him here. And we're also excited to people put themselves on mute, please, when they come on in. That'd be helpful. See if I could find who that is. Okay, great. Next slide, Shams. Just to tease the upcoming Lunch and Learns, next week we have an interesting talk on considering VAD placement in the home, which I'm really excited to hear about and should be interesting. And then following, we have a nice talk on management of inflammatory bowel disease by two of our great Mass General specialists who come to Newton-Wellesley. And then we have on the 25th, another dermatology talk, which is great, common rashes. Always love to see that. Next slide. Oh, that's a reminder also that this is these talks are good for Category 2 CME. Sorry about that. Just to remind folks about the physician wellness initiatives, you folks on this have heard me talk about these before. We are, there's a Thursday night meditation drop-in session. Next slide. And then the concierge system, which we have talked, I want to talk fast because I want to give Shams as much time as he can. We are coming to you live today from TripAdvisor, which is our patient-centered vaccine center. We're giving vaccines right around the corner, right in the down the hall here, which has been amazing. For those of you who are interested, come sign up for a session. We can use all sorts of help, giving shots, checking in, just saying hi to people. It's really fun. It's a cool vibe down here. It's one of the greatest things I've been doing during the pandemic. So I plan to be hanging out here a lot. It's really, really a great feeling down here, especially with this first population, the 75-year-old and plus. So we want to encourage folks to sign up. That's been out there. Links have been out there. And if you want, we can definitely get that out more. And Audrey's texting me saying I should have made a slide, and she's right. But I'll do that next time. Anyway, we also want to encourage folks to join Dr. Friedman and his crew on Wednesday morning at 8:30 for grand rounds. And those topics are forthcoming as well. Next slide. All yours, Shams. Thank you.
Thank you. Thanks, John. Thanks for the nice introduction. And hello, everyone. As John already mentioned, yes, like we do work together, the whole group, I guess, but we only know each other through email. So it's a good way to put a face in front of the name and the email. Good. So I am Shams Iqbal. I'm the Chief of Intervention Radiology. And today I'll be talking about the management of BPH, what IR can do to help those patients out. So disclosure, these are my disclosures, nothing pertinent. So a little bit about IR. So as you, most of you are aware of that, IR was like somewhat of a no man's zone since a long time. And then MGH took over this responsibility and they were still like not as efficient. And then 2 years ago, I was deputed with this role of building the practice here and developing the field of IR for Newton-Wellesley. And in almost 2 years, I have seen that it has grown significantly. So we are located in the main building and on the first floor and the second floor, a part of the radiology and some part in the cardiovascular center. And we offer the entire gamut of procedures. It's too many to enumerate, so I just put in a couple of things which I felt that might have made some sense for providers like you. And if you, I would say like, if you have any questions which can have a effect from the imaging perspective and procedure perspective, feel free to reach out to me. I'm available through email and I try to respond as quick as possible. And while doing that, I also felt that like we are sitting on a very good patient population and we have so many things to offer. So I started building programs and so far I've been able to start like 4 or 5 really up and running programs. That includes the spine program. I have been offering kyphoplasty for older patients with spine compression fractures with collaborating with Jessica Edlin, and RCC ablation, we have been doing some, and then liver cancer and tumor ablation. Prostate artery embolization is what is the closest to my heart because I am leading a program with the urologists at the main campus MGH as a part of the Prostate Center of Excellence. And we offer quite a wide variety of treatments for those patients. And we think of like doing some, we are in the process of doing some research protocol also for the patient who have like cancer also. So we are trying to expand the indications. And TIPS is something for portal hypertension. These I have written down my email and the number. You can call us anytime. This is our nursing station number. They will locate us, or you can page me. I'm available on the paging also. This is me and Carlos Giro in my PA. He's a very good resource to get a lot of work done from IR. So overview for the talk today. Today I'm going to talk about benign prostatic enlargement and the associated symptoms of lower urinary tracts, and discuss management options, including the risks and the benefits, and introduce the minimally invasive option of embolization for BPH from IR perspective. So what is BPH? As we all know, like we have this organ just by virtue of being males, and this is the prostate is sitting right underneath the bladder. It's a pear-shaped structure, inverted pyramid, if you say so, and it has like 5 zones. And the zone which is surrounding the urethra is known as the transitional zone, periurethral transition zone, and that is what's involved in the hypertrophy. And over time, with age and all the hormonal changes, it grows in size, it grows in numbers. So like there's hypertrophy and hyperplasia both, and there's significant fibrosis that causes significant pressure on the urethra, causing the compression. And this is known as bladder outflow obstruction. And then the bladder keeps on fighting against it, having trabeculation, thickened wall. And there are times when the bladder fails, and then the patient starts feeling that thing, symptoms known as lower urinary tract symptoms. So it's a sequence continuum of BPH leading to BOO leading to LUTS. Epidemiology wise, like half of the population will be involved in this if they live long enough, just by sheer being male. And it affects about 20% of patients from 40 to 79%. And with increasing age, it's becoming a proportionally increasing size of problem. And a lot of healthcare dollars are diverted towards it. The way I remember easily is like the easy way to remember is like at 70 years of age, 70% of population will have BPH, and quarter of those will have significant LUTS. So there's a huge population out there who needs treatment. And just by virtue of the place where we practice, Newton-Wellesley, we have a significant older population who needs help in this realm. So, and that's why we have been trying to figure out different ways of treatment and different ways of helping them out. Risk factors, as I already mentioned, anybody with older age, more than 50 years, is a significant risk factor. Sedentary lifestyle, smoking, alcohol, and the chronic medical conditions, including hypertension, diabetes, heart and circulatory diseases, and obesity. Family history of BPH makes it significantly higher risk for the patient to develop it. And ethnicity plays a significant role. Like I have seen in my experience, the African American and Hispanics they have like a little more advanced disease at the same age. Not only have more incidence, but also like a little advanced disease also. So what are the components of LUTS? LUTS is defined into 2 components, the static component and the dynamic component. The static component deals with the storage aspect of the urine, which leads to the issues of urinary frequency, urgency, incontinence. And the dynamic component is when the patient is trying to go and the patient is not able to do so. And even if they're able to do it, it's very weak stream, or the stream is interrupted, or the stream is like not able to empty the bladder, and they have a feeling of residual urine, and they have to go like every hour to 2 hours, and like at a much shorter period of time, which than what they would like to. So like, what are the causes of LUTS? Just to say that everything which causes LUTS is not BPH. So we need to figure out what are the other causes and how we can exclude them. Because when I see the patient in the clinic, I exclude all these things because we want to treat what is the cause, not like just any enlarged prostate. So the most common things are stones. It could be in the ureter, it could be in the bladder, they have foreign bodies, urethral strictures, and all kind of tumors, including prostate cancer, bladder tumor, and bladder wall dysfunction. There is a gamut of problems which can lead to all these things. So we have to treat them accordingly. We cannot embolize everyone or treat with minimally invasive procedure from the urology standpoint who have LUTS. So we have a big part of our job is to ascertain that this bladder outflow obstruction is a real correlation with the LUTS. Because if we don't do that, we are waiting to fail. Because if the issue is bladder overactivity and we treat the prostate, the patient will come back and say like, hey, you did not treat me, and the entire hard work is going waste. So I spend significant amount of my discussion with the patient to exclude anything else, and we do a lot of imaging and other tests to prove that this is the reason before we go ahead and the treatment happens. So what are we looking for? So we're looking for a set of patients. If you look at this Venn diagram, we are looking for the patients who are overlapping all those Venn areas, which is a patient who has histological BPH, and on imaging patient has BPH, benign prostatic enlargement, and it's causing blood outflow obstruction, and which is causing bothersome LUTS, and we can treat and can have good outcome. So how do we manage it? As I was mentioning, so this is a chart from the American Urological Association guidelines. So they define the LUTS into two ways of managing: a basic management and the advanced management. In the basic management, we are looking for any modulation of lifestyle, like urine or fluid overload and other things, and giving some medication and see if we can manage it by that. So it's an initial stage of management, and the management is usually conservative by medication or modification of lifestyle. If this does not happen, then we go to the next level, which is this chart, where we start doing invasive tests and try to prove that what we are looking at is really a prostate artery enlargement leading to BO and LUTS. So in this way, we start doing tests, invasive tests like Euroflow study, urodynamic studies, which I'll touch in a little bit. And then once we ascertain those, we start offering options, minimally invasive options, surgical options. TURP, transurethral resection of prostate. It's still the gold standard of prostate enlargement leading to LUTS. So the issue with this is like it's a surgically invasive procedure, but it has a limit of size. Any prostate which is more than 80 grams, you tend to get like less effective outcome, and you have like significant sexual side effect. We have retrograde ejaculation, you have impotence, and all the nervous irritancy is like taking, they use a bipolar cautery, they go in and take single salami loops through the urethra. And while doing that at the bladder neck, they're like nerve endings, they're destroyed, so they can have sexual side effects. Significant number of patients do have that. So that's why we are always looking for minimally invasive management. Patients who have like huge prostate, like 100 grams or more, the only good option presently is open prostatectomy. But as we all know, open prostatectomy has a large morbidity involved with it. Like usually the average hospital stay is about 7 days, and there's a significant blood loss, at least 4 to 5 units. So like we need to choose our patient appropriately, and we need to look for alternate option. In this day and age of minimally invasive approach, everything, we should look for new options down the road, and we can develop those. So that's how all these minimally invasive management and prostate embolization came into being. So what are the options for treatment? The first one is a waitful watching. When we do the evaluation of the patient and we feel that the symptoms are not as bad, we are in the basic management level, we just waitfully watch and we try to manage conservatively. And we give some medication, alpha blocker, 5-alpha reductase inhibitor, finasteride, phosphodiesterase inhibitor. These all involve the static and dynamic component, and also PD involves like both static and dynamic component, but they are not as effective, and they also have their own side effect, sexual side effect, including the 5-alpha reductase inhibitor. So patients don't like it, and a lot of patients, so we have to treat patients for 3 months before we go into the next level of surgical and minimally invasive treatments. Surgery, as I mentioned, transurethral resection of prostate and open prostatectomy, they have their own indication. And that issues which I expressed about the TURP and open prostatectomy led to the development of multiple invasive, minimally invasive treatments, multiple in numbers by the urologists. And they have the laser is a photoselective vaporization, HOLEP is holmium laser enucleation. They have resume where they go in with a catheter, and they have side firing steam which burns the tissue surrounding the urethra. Urolift is like they go and put 2 clips on the side and lift the prostate, but it's dependent on the sagging of the pelvic floor musculature. If it's sagged, then you have the same angulation and same issue. Microwave, they put in a wire, and through the wire, they have like microwave in a circumferential fashion. All these things work to a certain size, like which as I mentioned, 70 to 80 grams, because after that, the orientation of the gland is such that the urethra does not stay straight anymore. So there's a high chance of making false path. For example, like just last week, 2 weeks ago, I did a procedure on a patient. He had like 130 grams of prostate, and I think they tried to do PVP, photoselective vaporization. But what happened, like they had a perforation because the urethra was like very circuitous. They went in, and there was one area where the prostate covering the urethra was not much, and they made a hole, and there was an extra peritoneal leak, and that led to an issue. So he came back, and we did the treatment, and I'll see him in like about 2 weeks and see how it goes. So far, he's been fine. So anyway, so we have all niche, like how we approach what we do, and we do all the discussions, and then we offer them all this treatment and see whichever the patient selects. If the patient selects like prostate artery embolization, which is more often than not because it's the least invasive and the best outcome, because we just make the prostate shrink in size. The anatomy is maintained. We don't cut into anything. We don't like slice anything. We don't involve any nerves. We just decrease the blood supply, and whatever the shape, even if the shape is very deranged, it just gets a small deranged shape prostate rather than like cutting and slicing things out. So this is how like I work up the patient in the clinic. When we see the patient, there are two groups basically. One of the group is like they already are at the stage where they are either CAC, chronic intermittent catheterization, or they have indwelling Foley catheter or a suprapubic catheter, again, which is placed by us in IR, and they're dependent on that, and they have multiple episodes of infection. In fact, like just this morning, I had clinic, and I saw two patients who have indwelling catheters, and they have at least 3 or 4 episodes of infection. And life is like the quality of life is like really affected. Again, first of all, catheter coming out of your either penis or the suprapubic aspect is not the best part. On top of that, because of this extrinsic interaction, they have infection all the time, and it's not fun to have a catheter coming out of you. So if those patients who are not catheter dependent, we ask for all these questionnaires, and the questionnaire is like in International Prostate Severity Scores. And then we have questionnaire about like quality of life, which is single question, sexual dysfunction, which is an extensive questionnaire, and then we have shame sheet, a bunch of questionnaires to be filled. This is the ISS score. This is a 7-point questionnaire in which we scale from 0 to 5, and we have 7 questions. So the maximum is 35, minimum is 0. Nobody has 0 ever. And this is quality of life. There's like just one question in the last 1 month, the way your life has been. If you have to live like that, how would you feel? And more often than not, they're like 4 or more. So, and erectile dysfunction is a very extensive questionnaire. I just give you the summary in the interest of time. And we look for the dysfunction, how much dysfunction is causing to the patient. After that, I follow with like imaging tests. So we do a urinalysis and we do like ultrasound. Usually, more often than not, by the time the patient comes to me, they do already have gotten the PSA, prostate artery, prostate specific antigen, and then I start doing those tests. So we look at for the PVR with ultrasound, and Euroflow study. If we are like a little unsure, we get those tests done, and then imaging for other indications. So the first one is ultrasound, transrectal ultrasound. This gives us a very good visualization of the prostate, gives us the size, the volume of the prostate, and it also gives us the median lobe and the post-void residual, because if you have significant post-void residual, the chances that we will be successful. If you don't, this means we have to look for something else. So uroflowmetry, this is the non-invasive study done by urology usually. What they do is like they have the measuring device and can basically, and a funnel on the top, and they ask the patient to pee. And we look for the time, the peak, the volume, and we look for all those numbers. So if somebody has like less than 10 ml per second, the peak flow, then this is a very distinctive sign of bladder outflow obstruction, because the patient just cannot generate enough force to have a healthy stream. And if it's more than 15, then like it's very unlikely. And you need to have enough volume in the bladder to ensure that you're looking at the right numbers. Specificities and positive predictive value in the range of 70%. This is a like real chart. The first one shows a normal bell-shaped curve. There is a normal patient. The second one and the third one, there's like tethering and there's fluctuation, intermittent. This is classical for bladder outflow obstruction. If the patient is like in the indeterminate range, what do? We have an invasive test, which is urodynamic study. This is a little involved because, again, done by the urologist. I send them to get this test done. What they do, like they place a catheter in the bladder, the catheter in the rectum. The rectum transduces the abdomen. So we need to have that pressure deducted so that we can get the absolute detrusor pressure. And with those, we get the numbers and we look for the bladder outflow index. And once we have those subtracted points with the Qmax, we plot them in these things. These are like charts where, as you can see, in one of the limb is PDET, detrusor pressure. The second one is Qmax. These are the things which you can get. The pressure is transduced by the catheter. The Qmax is got by the flowing device. And we plot it and we figure out if the patient falls in this blue chart, the patient is obstructed. So prostate is the issue. If the patient is in the white, no issues. We should not be treating the prostate. I mean, in the equivocal, always you'll have some patient falling into that. Once we finalize that, yes, prostate is the issue, what do we look for? So I have to look, since I'm doing a vascular procedure, I need to look for the vessels. And CTA is the best for blood vessels. So we get, with the CTA, we get the prostate size measured. We look for the median lobe. Again, median lobe should not be too big. We look for the vascular anatomy, and that defines our success, because again, it's a very challenging procedure from our perspective. And MRI, if there's a high PSA, we want to exclude the carcinoma prostate before we do the treatment, because we are writing a protocol in which we are trying to involve patients who have carcinoma prostate and LUTS so that we can see how things go in them. So who are candidates for prostate artery embolization? Anyone who has an ISS score of more than 13 and they have failed the medical therapy. As I said, 3 months is usually time, but more often than not, patients have side effect and they don't want to try anymore. A Euroflow study showed less than 10 ml per second, PVR of more than 100, and prostate size of more than 50 grams. And their contraindication, these contraindications are the ones which are the other causes of LUTS, including mostly cancers, stones, and neurological dysfunctions. So from your perspective, like who would you be thinking for these treatments? So anyone who has an indwelling catheter, they should have an evaluation by IR, a clinical visit at least. Patients who are living with that way and they're enlarged prostate, BPH, and not a surgical candidate, because a lot of patients have cardiac problems, other problems, and they cannot be surgerized. So, and poor surgical candidate, the same lines. Large prostate, anything above 80 grams, then TURP is not a good option. Open prostatectomy is very morbid, so those patients are very good candidates. Refractory hematuria, again, this is how it all started. When the first prostate treatment started, it was patient with enlarged prostate with bleeding, and we treated it. It happened in New Jersey, so we are very proud that like USA started one of these procedures. So, and patients who are wary of sexual side effect from other treatment, including the medication. From patient perspective, again, the same thing in a different angle, like ineligible for surgery, medications are ineffective or side effect. They want to avoid the retrograde ejaculation or impotence, and patients wishing to maintain fertility. So I'm sure like the place where we're sitting in Newton-Wellesley, we have a significant amount of patient population who are very old and we are suffering from their enlarged prostate, and they're not being treated because they're not, urology does not have a definite treatment for those. So, and that's where we come in and we are happy to help to get them a better quality of life. Technique-wise, so we go from the right groin, we access under ultrasound, go in with the catheter, cross it, do the pelvic angiogram, and do a bunch of DSA, digital subtraction angiogram, which is what this image is. And then we do a cone beam CT because we have to be very sure which vessel we are treating, because there are significant vessels around there, like the rectal branch and other branches. So we are very, very cautious about not treating anything else. So this is the anatomy, as you can see. And you can see this angiogram on this side, and the arrow points to the vessel, which is the prostatic artery, and which is defined by, there's a Foley bulb, as if you can see my cursor going around. So this is the branch which you have to select, and all these big branches which you see, which will be easy to get, but we have to go into this small branch. And that's what makes this procedure a little challenging. It takes at least a couple of hours to get it done. This is an anatomy on a cadaveric, which says like how the prostatic artery is a very variable origin. So how they're most commonly originating from the internal pudendal artery. And this is another patient which I just did like a couple of months ago, and you can see the Foley is as a guide. And I marked all these things and with like inferior gluteal, pudendal, and the vessel which is of interest for me is this mark with the asterisk. As you can see, very faint vessel, but this is good enough to treat the patient and taking care of that. And as I said, like, so I select that branch, go into that branch and do a DSA. The first image is a DSA where you can see the blush, the tissue blush, And then we do a advanced imaging in which in the fluoro room only, the scanner rotates around and gives like a poor man's CT is what we call it. We call it Dyna CT. And then you can see that the enhancement is only in the prostate and nothing else is enhancing. So we are good to treat. Adverse event, it's a very safe procedure. Major adverse events are only about 0.5%. And of those, like in literature, all of them were treated conservatively. No surgery was needed. Only one cystoscopy was needed for a bladder issue. Minor adverse event about 2.5 to 4.6%. And they're all like managed medically without any issues. Follow-up, I see them in about 4 to 6 weeks. And if the patient has the indwelling catheter, we try to remove at 1 week and try every week and see. Usually like literature say like 1 month, but I have tried till 3 months, and one of the patient did remove the catheter in about 2 months time. So I'm a little bit more persistent on that. And then we follow at 3 months and 6 months, and we do some ultrasound imaging also. Outcomes, so usually the IPSS improves the IPSS score by 11 to 18. A 3-point IPSS score improvement is perceived by the patient, and we expect about like 9 to 12 in the improvement. Quality of life is significantly improved. Technical success rate is about 86 to 100%, and all those peak flow rate is increased, post-voidal residual volume is decreased, and reduction in prostate volume, again, is not significant, but sorry, I think take that. Yeah, and then erectile dysfunction is not involved at all. Literature-wise, it's a very active area of research, and we have like 3 randomized controlled trial, and we have a significant number of papers. They are all supporting this data. And if you can see this chart, I got it from the PubMed, and there's a hyperbolic curve, and the number of papers in the last 2 years had the highest number of papers being published. A lot of work is going on there. Present state of approval, FDA has approved Embolization for this indication. NIH approved this procedure in 2018. AUA is considering to put it as one of the standard treatments. And SIR, the multi-society guidelines, approves it at a level of evidence B, strongly recommended. Again, for those who came in late, I'm Shams Iqbal. I'm the chief of IR here, and my team involves, we have 12 people who rotate through this door from MGH. Carlos and me are the most persistent people here. I spend like significant amount of my life here. And we offer the entire gamut of procedures. And if something which we can't do here, we have means by which we can get it to the main campus and help you out. Feel free to reach out. This is my email, and any questions, thought, queries, I'm happy to help. This is my number. And that's all, folks. Questions?
Thanks so much. Perfect timing. We got about 2 minutes left. I do want to offer folks after 1 o'clock, I'm happy to stay on this call for 5 or 10 minutes if anyone has any patient vaccine questions. I know there's a lot of questions amongst our PCPs, et cetera. So I will stay on after that. But any questions for Shams, you can throw in the chat box. One question I had, Shams, was you mentioned briefly about screening for prostate cancer, with the PSA. If you should do an embolization, then find a cancer in the prostate afterwards, is that an issue, or what's the situation there?
It's unlikely to find a cancer with angiogram because it's not as specific, because usually if you're missing in a cancer with all the imaging which we did before the treatment, it has to be like really below 1 centimeter. And I don't think even with angiogram we see that. And there are like 2 studies which just came out of Europe, is where one from Portugal, one from Switzerland, where they did go after patients who have like intermediate to low risk prostate cancer, and they treated those, and then they did biopsy, follow biopsy in 6 months. They were all negative for cancer, and they were Gleason 6 or 7, 3+4, not 4+3, and so this is a very active area of research. So I think that should not be an issue if we see something of those kinds.
That's great. And I guess I can't let this one go, but did you say salami loops when you talked about a TURP?
No,
I hope nobody was having salami sandwich.
You will see that, and I bet you if you come up with any other word.
It takes lunch and learn to a different level, my friend. So that's Shams. He does a lot of stuff for you guys. Any problems, he's so available. Thanks so much for doing this. We'll put that on.
I see in the chat box. Did you see that? For patient in the 60s with weak stream, do you recommend we prefer you to studies prior to trying?
Oh, I can't see that. I don't know why. Go ahead, read it out loud. I can't see it.
McNanny. And the question I read is like, for patients in their 60s with weak stream, do you recommend we refer to you for urodynamic studies prior to trying Flomax? These are patients with normal urine analysis. I will say like there's no harm in seeing them, but Flomax should be the first way to go. And urodynamic studies comes after we evaluate the questionnaire and we feel that the patient has an IPSS score of less than 11 in the lower risk, and we still feel strongly that this could still be because of prostate enlargement. Then we try to define with urodynamic studies that whether it's prostate is the problem or something else. If these patients, I see them and they fill the questionnaire and they have like significant signs symptoms from the IPSS score perspective, they do not need urodynamic study, because urodynamic study is a rather involved procedure. We only need it for patients. It's like kind of it's solving a question where we are unsure.
Yeah, I guess Sally's probably also asking, we get folks, we start them on Flomax, they don't get better. Generally, a lot of us will send them right to our urological colleagues. Should we be talking about the PAE procedure and send to you? Or our urology referring to you after they see them?
I would recommend, like, either way is fine. Urology has like significant other opportunities also of treatment. But what we see is like, the patients are unaware of the prostate artery embolism at this present. And one of my biggest point is to educate them. And that's what I'm trying to live the life of, like, as an educator, tell them that there's a minimally invasive, since it's like a cost field, you might expect some issue that prostate artery embolization is not offered or not even talked about. So that's why if you guys inform them, like, or maybe I'm happy to see them in the clinic, tell them like, these are the options. And then, the indication is what drives us, not what we can do, because we can treat, everybody has a prostate artery and I can embolize everyone, but I don't want to, because you only do when it's needed. But the other part of the story is like, they need to be educated. They need to know that this is a possibility, rather than risking, like, for example, patients in 60s are the most vulnerable, because they still have a active sexual lifestyle, and they, more often than not, after the procedure, they cannot perform that, and it's very depressing. They go into depression, like it's a known fact. So and that's why even urologists have been trying to find all these minimally invasive procedures, because they want to avoid the sexual side effects.
Sure.
And that's where we come into being.
All right. Thanks so much. Really appreciate it. I hope everyone has a good day. I hope everyone enjoys the Super Bowl. Can't believe we made it through the whole season without COVID closing us down.
Brady, or like, are you against or pro Brady?
I don't know. I guess that's the question across the state. I'm definitely voting for, I'm pro TB, that's for sure. So thanks, everyone. I'm going to stop recording, and I'll stay on if people want to throw questions in the chat or just jump on out. Thanks, Shams.